So I have the charge to answer some ambiguous question about regarding active surveillance in prostate cancer. So my first slide will be just a definition what is active surveillance for prostate cancer. We all know that most prostate cancers progress very slowly, and the window of opportunity to cure most prostate cancer is very wide, years or even a decade long. So active surveillance means avoiding overtreatment by deferring surgery, radiation, or other treatment until there is a sign that the cancer may be getting worse, and instead monitoring it carefully. If the cancer seems to be worsening, then the goal remains treatment at that time. We then attempt to cure. So active surveillance is a standard of care for most low-risk prostate cancer, and it's endorsed by all the guidelines, the major guidelines around the world. What are the determinants to talk about? What determine whether the patient is low risk, intermediate, or high risk? We look at different parameters. And determinant for active surveillance eligibility is PSA below 10. You all know these parameters. PSA density below 0.15, volume of the prostate cancer under 15% and 2 cores maximum. Stage T1, T2, pathologically grade, genomic nowadays, age and health, and patient and family preferences. And I will add ethnicity in some country. So the typical schedule is PSA blood testing every 6 months, prostate MRI imaging every 18 months, MRI or target biopsy every 2 years, and genomic testing nowadays for more selection of the patient. Active surveillance nowadays in 2020 and 6 should be tailored to the individual patient. It is a shared decision making between the patient and the provider where the low-risk stable cancer will have less aggressive surveillance. So let's see the answered question in the literature. What are the answered questions? The first one is the outcome of active surveillance in long term. This is a paper published in 2020 in Journal of Urology about 1,450 patients. Median follow-up were roughly 7 years. 90% were GG1 and 10% were GG2. So the 7-year biopsy upgrade free survival was 40%. We can state that progression of disease on active surveillance is common. Also, the 7-year treatment-free survival was almost 60%. 40% of the patients progress and go on to get treatment. 7-year metastasis-free survival and 7-year prostate cancer-specific survival are very good. Metastases are very low. So the conclusion, active surveillance seems to preserve favorable long-term prognosis, as metastases and prostate cancer-specific deaths are rare. Is active surveillance safe in younger men? Well, the rationale for this article is concern of all the providers, all the clinicians about active surveillance in younger patients who will need to be on surveillance for longer and may need definitive treatment down the line. So this is a series about 1,430 patients, younger age, below 16, was associated with low risk on biopsy, of biopsy upgrade and biopsy progression. So there was no significant association between younger age and time to treatment or recurrence outcome after surgery. So we can conclude that younger patient age was associated with decreased risk of biopsy-based Gleason score upgrade during active surveillance, but not with the risk of definitive treatment in the intermediate term. Active surveillance could be and must be a strategy to mitigate overtreatment in young patients with a low-risk prostate cancer in early term. Is active surveillance safe in high-volume, low-grade prostate cancer? I will say yes. So the rationale is patients with higher volume, low-grade prostate cancer are frequently managed by surgery or radiation, but this recommendation is based on all data. This is a series published in Journal of Urology when 1,000 patients underwent radical surgery, radical prostatectomy for high volume, increased tumor. Tumor was not associated with prostate cancer outcomes or having a major biopsy upgrade or biochemical recurrence after surgery. So you can see, the take-home message in men with Gleason grade group 1 prostate cancer, tumor volume may be associated with upgrading on radical prostatectomy, but not more clinically significant outcome or adverse pathology on recurrence or recurrence. The next question is, does delayed surgery for this patient lead to worse outcomes? The rationale is opening of active surveillance for this patient, especially for younger patients. Fear that delay or definitive management of patients found to have higher grade disease, the GG2 group, will lead to worse outcome. So this is a series about 1,259 patients underwent surgery. And in this series, you have 3 kinds of patients. You have the ones who have the initial diagnosis with 3+4. You have this patient on active surveillance who upgraded to 3+4. And you have the third one where the patient on active surveillance who upgrade to 3+4 but remained on active surveillance for more than 12 months. Timing, the conclusion is timing of definitive surgery, whether upfront or delayed after upgrade on active surveillance, was not associated with risk of recurrence. And this findings support the safety of active surveillance and delay definitive therapy for subsets of patients with GG2 prostate cancer. This is what we have in the literature. This is the answered question. What are the non-answered questions or unmet need regarding active surveillance? Should all Gleason score 6 be renamed as non-cancer? Can indolent prostate cancer be reliably detected on biopsy? Can we skip systematic biopsy? What histological characteristic on repeat systematic biopsy should lead to change in management? Is there a sufficient data on multiparametric MRI and PSMA to address whether they use could potentially supersede other clinical triggers of change in management during monitoring, such as changes in PSA, DRI, and histological characteristic on repeat biopsy? Let's see if the literature can have the answer for all this question. The first one, should all Gleason score be renamed as non-cancer? Well, when you look at the literature, this is a summary of autopsy of men that died in car crashes or heart attacks, whatever you like. By the time you get 70s, if you are black man in US, or 80s as white man US, 50% of all men have what looks like GG1 prostate cancer under the microscope. So you can almost think that this is a normal feature of aging. And the debate isn't new about renaming prostate cancer, GG1 prostate cancer, as non-cancer. There are papers against and ones who are with renaming GG1 as non-cancer, as well as all now. There is a paper more than 10 years ago that's already discussed and mentioned this. And this issue has been intensified and brought about by the overdiagnosis and overtreatment of low-risk prostate cancer, especially in the US. So to understand this, we have to dig deeper in the Gleason score 6, looking back at the original Gleason score when Dr. Gleason created this grading system. When you look at the literature, you have almost diametrically opposing views of pathologists and clinicians. The first, if we conduct an investigation among the pathologists, ESOP survey was about 340 pathologies, and almost 90% endorsed retaining GG1 as a cancer. We ran the same survey by the second most big association of pathologists in North America, GUPS survey on 240 pathologists, and also 82% were opposed to removing the name of prostate cancer or cancer for GG1. So there is no society level discussion yet on pros and cons and options for renaming. But, well, the group who are the pros of retaining cancer label in GG1 have their argument, and the other one have their counter argument. For the pros, the main reason is the GG1 has histological and molecular feature of cancer, mainly PTEN loss, BRCA loss, cancer for, and we have the cancer for reproducibility of Gleason pattern 4, etc. And if left untreated, may have unfavorable outcome. For the cons is about the behavior of the tumor. So this author says that, well, this tumor is enabled to metastasize, so very indolent tumor behavior, which lead to overdiagnosis and its negative downstream effects on the patient. Well, those who said that retaining cancer label in GG1 have this, so this is another paper who talk about PTEN loss, where 101 patients with a low-risk prostate cancer, according to EAU criteria, they should go to active surveillance. But these patients choose to have prostatectomy instead. So, and when they went to test, this is a patient that were reclassified as ISAP 2 or 3 on biopsy during the surveillance. And when they went to test PTEN loss in the tissue of the specimen of radical prostatectomy, they saw that overall PTEN loss was happening in 13%, was correlated with Gleason score upgrading, and there was PTEN loss had 10-fold higher chance of upgrading compared to the cancer that didn't have PTEN loss. So this is the way to define aggressiveness of GG1 cancer for the pros who retain this. The second one is, can indolent prostate cancer be reliably detected at biopsy? So the response is, so guys, so far so good, we can, but the main point is that the most of the time, our patient just gets a biopsy, and we know that there is a risk of misrepresentation of the grade related to the biopsy and its efficiency. I just want to present this paper, published a few years ago. He was considering around 105 patients in this cohort that were qualified for active surveillance according to the EAU criteria. So despite this, they decide to go for radical prostatectomy. And when they look at the concordance between the biopsy and the specimen on radical prostatectomy, we could see that up of 30% of the patients were categorized, were upgraded, and there was extra prostatic extension in almost 7% of the patient. So if this patient were categorized based on the biopsy, 13%, 1/3 of this patient of the time, we would have underestimated this cancer. So can indolent prostate can be reliably detected on biopsy? We all know a subset of GG1 at biopsy are upgraded to high grade on radical prostatectomy, just I mentioned before. We know that GG1 reclassification on active surveillance may represent a previously unsampled higher grade prostate cancer, which we don't target at the biopsy. It could be a progression of the same tumor or de novo high-grade tumor. We don't know. A subset of GG1 biopsy are associated with prostate-specific mortality, even it's rare, it's around 1.5%. And we have this problem with MRI where PIRAS-3 are visible or non-visible on MRI. So we don't know. So there is a higher inter-observer variation in diagnosing a subset of Gleason pattern 4? So the response is no. We can't reliably detect indolent prostate cancer on biopsy. We should have another thing to improve our diagnostic. So, but I think that perhaps we are asking the wrong question. I think the question will be, is there a low-grade indolent entity within prostate cancer redeemable? In fact, and this is my opinion, the group of GG1 cancer can contain two parts, where we have this part of indolent prostate cancer, and the second part, the patient who have PTN, loss, BRCA mutation, ETM, TP53, and all this stuff who will drive them to treatment or upgrading during this surveillance. But current diagnostic technology are incapable of accurately identifying indolent prostate cancer. So the only way is to monitor them. How can we improve the ability to correctly classify indolent prostate cancer? We need what? Histological definition that's captured, that's not defined. Indolent cancer which include GG1 with no equivocal GP3 or GP4, no cribriform carcinoma, and no stromal dysplasia. And this is a big problem because you have big variation between the pathologists. We need to strengthen the selection and monitoring criteria for enrollment that help in reducing biopsy grade reclassification during active surveillance. And we need a novel biopsy approaches which may help in reducing detection of clinically insignificant prostate cancer. What is the next? Can we skip systematic biopsy? There is a lot of literature about this. I will just show you this. This is an article published in 2055 when 1,800 men on active surveillance with MRI fusion targets and systematic biopsy, almost 1,200 biopsy, detected 82 GG1 and 18 GG2. Target biopsy identifies significant cancer in 95% of cases, and 5% were diagnosed on systematic biopsy only. So the conclusion, no need for systematic biopsy in men on active surveillance. Take this with caution, I will say, because the improvement of MRI still to be there. The second question, what histological characteristics on repeat systematic biopsy? You have your patient on active surveillance, you plan to do a biopsy into the next year or 2 years. What histological characteristics on repeat systematic biopsy should lead to change in treatment? Well, the first one is the grade, the Gleason pattern 4. To determine the association between cribriform pattern, this is a paper when they looked the prognosis of pattern 4 and cribriform pattern on biopsy and pathological finding on subsequent prostatectomies. They evaluated the presence of cribriform architecture in prospective cohort of 300 men and GP4 with cribriform morphology on biopsy showed a statistical significant association with higher increase, pathological stage, and nodal metastasis. So this large prospective study demonstrated that cribriform pattern 4 is associated with adverse prognostic future and highlight the relevance of recognizing specific morphologies with distinct biological and clinical feature. But, there is a but. Do we know how to quantify cancer volume? This is a study of a patient from University of Chicago and University of California, excellent institution, great pathologist, very similar patient, and there is a four-fold differences in the pattern 4 amount recorded by the pathologist in those institutions. You imagine. This is a work from Dutchland. They actually looked into this. Why there is huge inter-observer variation. They said, well, the reason why you get these big differences between pathologists is that they are following different algorithms. So as shown on the top, you have just look at the pathologists just look at the large focus and measure that, while other which is in the middle will add up the different foci, and other center will not only add up the foci, but also interfocal distance stroma of benign tissue. So we can't actually get pathologists to measure biopsy cores in different ways and see which one is the best. But we can teach the EI, and this is the future. The last one is there is sufficient data on multiparametric MRI and PSMA to address whether the use could potentially supersede other clinical triggers? Well, I think we all, when we see the images in MRI and the evolution of the radiology, we all say that MRI is the solution. While prostate MRI has improved the detection of significant prostate cancer, we all know this, and is associated with outcome and active surveillance. But biopsies are relatively invasive procedure. So can we rely on MRI without biopsy? This is the first paper published in 2020. This was a single-center study of men prospectively enrolled on active surveillance from 2001 to 2017, almost 400 patients with low-grade disease. 22 of men with negative follow-up on MRI were found to have upgraded disease on surveillance biopsy. They were negative on MRI. They were positive and have ESOP 2 or 3 on biopsy. So the negative predictive value of MRI, still low. For biopsy upgrade was as low as 57% for men with PSA density above 0.15. So the takeaway home message is MRI should not replace biopsy for the moment. Another paper published 5 years later, European Urology in 2025. So the use of MRI rather than routine biopsy to look for change in cancer whilst on active surveillance allows us to treat men to avoid biopsy by 5 years. So this is a study about 1,150 patients when 412 have had a Gleason 3+3. So MRI visible disease was more common in those with Gleason score 3+4 than in those with Gleason score 3+3. But still, I mentioned this before, and this is the unmet need, is those patients with Gleason score 3+3 visible on MRI are really the Gleason 3+3 or other things. There is a debate on the molecular imaging. So over time, the cohort shifted from having primarily non-visible Gleason 3+3 to MRI visible 3+4 as the most common category of those starting active surveillance. And the event-free survival rate at 5 years was 91% for non-visible Gleason score 6 versus 71% for visible Gleason 6 and 70% for MRI non-visible Gleason 3 plus 4 versus 44% for MRI visible Gleason score 3 plus 3. So the conclusion is fewer than 1 in men, 1 in 10 men with Gleason 3 plus 3 disease not seen on MRI had active treatment by 5 years, 1 over 10, versus over half of men with the Gleason 3 plus 4 disease visible on MRI had active treatment by 5 years with 20% shifted to Gleason 4 plus 3. MRI is the solution. The conclusion is prostate cancer active surveillance without biopsy, not quite yet, but watch this space because the things are evolving, are getting. So given the current state of MRI accuracy and consistency, it would seem that for the time being, retention of routine but widely spaced use of biopsy is essential, particularly outside of center of radiology excellence. So my conclusion, can I skip biopsy and just get MRI if it is asked by your patient? Definitely not before the confirmatory biopsy. MRI can miss 1/4 of increases in grade even with specialized radiologists. After the confirmatory biopsy, interval can vary greatly based on PSA trend, MRI stability, and other factors. So can PSMA be the solution? Well, a growing body of evidence has demonstrated that the Civmax of the PSMA PET scan is associated with high proportion of pattern 4 disease and infrared pathology. And in the literature, as such, there has been considerable interest in whether PSMA can be incorporated in active surveillance protocol to improve risk stratification or exclude patients based on high-risk imaging findings. So can we rely on PSMA PET? Well, this is a paper published last year in Journal of Clinical Medicine, where they asked the same question. This is a large retrospective study of 1,123 patients who underwent PSMA, followed by a radical prostatectomy, demonstrate a strong correlation between Civmax and the likelihood of finding grade group 3 prostate cancer. And they conclude, the authors suggest, that patients with intraprostatic lesion and Civmax over 11 should not undergo active surveillance, as it's very likely to be higher grade prostate cancer on definitive treatment. Conversely, a Civmax below 5 is strongly associated with a low likelihood of pathological upgrading to grade higher than grade group 2. So the conclusion, this trial, along with other further research, will hopefully determine whether incorporation of PSMA into active surveillance protocol provides significant clinical utility. So this remains an ongoing area of research likely to develop in the upcoming years. I want to mention, I will not go into detail because this is prospective data run by Lawrence Close, comparing it's a randomized trial comparing micro ultrasound versus MRI in the active surveillance field. The images are very detailed and very promising future. So the last one is molecular genetic biomarker are the solution. So despite improvement in diagnosis technique, mixed classification and diagnosis, and the limited ability to predict disease progression remain major challenges in active surveillance. So novel molecular and genetic biomarker assessed throughout liquid biopsy approaches offer the potential to redefine or to refine patient selection and support risk-adapted monitoring in active surveillance. So can we rely on genetics? So this is the last paper published in 2026, where they state that blood-based assays such as Phi, 4K score, United test, including ExoDx and all the tests we know, signature have all shown association with disease progression or decision to undergo early treatment. The major hurdle for novel biomarkers is their ability to demonstrate not only predictive accuracy, but also clinical utility and cost effectiveness, as well as sufficient incremental benefits over established current clinical tool, reducing unnecessary biopsies without compromising oncological safety. So the conclusion, the goal is to transform surveillance from one-size-fits-all protocol into a biologically informed, personalized approach that maintains safety while minimizing harm. The future will be a lot of a predictive model demonstrate strong performance in distinguishing progressor from non-progressor, suggesting that radiomic analysis combined with machine learning has significant potential to enhance prostate cancer management. This is the future. I think this already exists. This approach could enable more personalized treatment strategy and improve clinical decision for patients undergoing active surveillance. So stay positive. It is important to remember that prostate cancer is usually slow growing. A 5-year survival is nearly 100% for localized cancer, even high-risk ones. And even men with advanced disease usually live for years with contemporary treatment. Treatment are improving all the time, and most side effects of the treatment can be managed. So take your time and make a treatment decision that makes sense to you and matches your priority. Thank you for watching and for the invitation.
Thank you, dear Said. It was wonderful. Thank you. Excellent presentation. The question from the floor.